The material presented in this educational activity is made available by HealthPartners Institute for Education and Research for educational purposes only. The material is not intended to represent the only or necessarily the best method or procedure appropriate for the medical situations discussed, but rather is intended to present an approach, view, statement, or opinion of the authors or presenters which may be of interest to other practitioners. Do not rely on this video without consulting with other health professionals or experts in the field.
Hello, I'm Loree Kalliainen, a plastic and hand surgeon, and I'm passionate about learning how better to optimize the prescription of postoperative opioids. It's essential that we address this topic because it's a huge patient safety issue. In this video, I would like to share with you a brief history of opioid use in the U.S., as well as our experience in standardizing the size of the prescriptions we write to tailor them to the hand surgery procedures we do. I will also discuss multimodal perioperative pain management strategies. These can be extrapolated to many types of operative procedures, and I invite and challenge you to apply them to your patients. We will cover three major topics around the development of a postoperative opioid prescription plan: the causes and challenges of overuse of opioid medication, a review of studies in this area, and identification of opportunities to improve postoperative care in our patients. During this segment, I'll share how these findings impacted my practice. From 1999 to 2007, Ohio's rate of opioid distribution in grams per 100,000 population through retail pharmacies increased 325%, while the unintentional drug overdose death rate increased 305%. This study was paralleled in other locations through the U.S. It isn't limited to Ohio. The Institute for Safe Medication Practices reports 78% of primary care physicians have been asked for drugs that their patients saw advertised on television, and 67% concede that they sometimes grant patients requests for medications that are not clinically indicated. In addition, data from the 2009 National Safety on Drug Use and Health study revealed that 55% of people aged 12 or older who engaged in non-medical use of prescription pain relievers obtained the drug they most recently used from, quote, a friend or relative for free, end quote. So what are some of the causes of this problem? We began to see altered prescription practices in the late 1990s when the Joint Commission began the Pain, the Fifth Vital Sign campaign. At that time, pain was being undertreated in patients, but the patients in question were primarily those with cancer. Unfortunately, the concept was extrapolated to all patients, and people became to have the expectation that they should have no pain. There was an increase during this time in direct-to-consumer marketing, and physicians began to be concerned that if they didn't cede to patients' demands for more opioids, they would be perceived as uncaring and be at legal risk. Prescriptions were written with the goal of giving the patient enough to keep them from calling back on nights or weekends. In my mind, an unusual philosophy of care. Currently, there is concern in the medical world that we are being held hostage to patient satisfaction survey results and are practicing to make people happy, whether or not this equates with good care. The outcome of this is an increased number of opioid pills in the community, which has led to drug diversion and overdose. I see a similarity between how we write prescriptions for opioids and for antibiotics. Over 20,000 people die in the U.S. each year of bacterial infections that should have been treatable with antibiotics were it not for overuse and the development of drug resistance. We're likewise seeing patient deaths from the overuse of opioids. To its credit, the Joint Commission has recognized that the current approach to pain has not been as effective as hoped. There has been a bigger push recently for multimodal pain management and management of expectations regarding pain. My interest in right-sizing postoperative opioid prescriptions began when I became aware of the discrepancies of the opioid prescription practices of the surgeons in my department. One day in clinic, I overheard one of the mid-level practitioners refilling an opioid prescription for one of my patients who had had a minor procedure. I became frustrated and asked why they were doing that for a patient who was healing without difficulty. And RN said with some exasperation, "You all," referring to me and my partners, "do things so differently. We don't know which of you wants what." I wondered if we were really that different from each other, so I asked one of our hand surgery fellows to look into the question. Our initial study looked at opioid prescription patterns among 5 surgeons for uncomplicated non-workers' compensation carpal tunnel syndrome. 30 patient charts were reviewed for each surgeon. Half of the patients for each surgeon were prescribed no postoperative narcotics. The other half received 10 to 40 pills for their initial postoperative prescription. The wide variation within and between surgeons suggested no good rationale for prescription size. We know that unnecessary variation in care leads to increased cost and complications. We'll return to my group's next steps a little later. So what does the literature show? Much of the postoperative opioid literature focuses on comparative effectiveness. This was not my interest. I am more interested in surgeon behavior. Jeff Rogers, a surgeon from Des Moines, and his 4 partners contacted patients after their hand surgery to see how many unused opioid pills remained. They were very surprised to find that almost 4,800 tablets were unused. Consider, please, the implications when expanded to the U.S. population. Dr. Rogers' group's findings were echoed by a dermatology group in Salt Lake City, Utah, which also found that 35% of their patients didn't use any postoperative opioids, and 86% of people who had opioids prescribed had pills left over. David Nelson, a surgeon in practice in San Francisco for over 20 years, has found that, on average, his patients used less than 1 opioid pill after undergoing open repair of a distal radius fracture. In my own practice of hand and upper extremity surgery, with a large proportion of trauma, people routinely say in their first postoperative visit that they used none of the opioids that I prescribed, used them only for a few days, or have pills left over. How then do we start to standardize our practices? How do we best minimize the number of unneeded and unused opioids in our communities? This is a patient safety issue directly related to physicians' practices. We know that changing practice patterns is difficult, but we must overcome the inertia. Surgeons may believe that no change is needed because their practices are safe and effective, or so they believe. Physicians may lack awareness of the risks associated with opioids. There may be a fear of change and of litigation, and there may not be awareness of or existence of best practice norms.
Federal controlled substance regulations prohibit the transfer of a controlled substance from anyone that is not a registrant of the United States Drug Enforcement Administration. Pharmacies and providers are not allowed to take possession of a controlled substance prescription once it has been dispensed to the patient. A few examples would include situations such as a patient requesting a stronger medication but has pills left from their previous prescription, or an individual simply looking to dispose of medications discovered when performing spring cleaning in their medication cabinet. Patients that bring controlled substance medications to a clinic or directly to a provider for disposal should be informed that they are unable to accept the medication. Remember, it is illegal for a clinic or provider to take back a controlled substance medication once it has been dispensed to the patient. The DEA did recently publish a change in the Federal Register that may impact the collection and disposal of controlled substances in the future. Additional work at the state and local level will need to take place to fully implement the change. Please visit the DEA website for additional information. Let's review some of the resources available to help educate ourselves and our patients on safe, proper methods of disposal. The DEA, in partnership with state and local law enforcement agencies, sponsors biannual national prescription drug take-back events throughout the United States. Over 4.1 million pounds of medications have been collected since the first scheduled event in 2010. Medication drop boxes are another option for individuals. The drop boxes are managed by local law enforcement agencies and offer a convenient, anonymous option to aid in the proper disposal of unused medications. When recommending these options, patients should be encouraged to leave their medications in the original labeled container. It is recommended that patient-specific information be removed or blacked out from the prescription label with a permanent marker. Lastly, individuals can dispose of medications at home if proper precautions are taken to ensure the medications are no longer fit for consumption. Medications should be mixed with an undesirable substance, such as coffee grounds or kitty litter, placed in a sealed container, and disposed of in the trash. Commercial products that use activated carbon are also available to aid in the disposal process. Talk to your pharmacist for more information on medication disposal bags. For the most up-to-date information, visit the Pharmacy tab on the HealthPartners website. There is a page dedicated to medication disposal resources. Together, we can do our part to educate ourselves and our patients on how to properly dispose of their unused medications and help protect the communities we live in.
After doing our initial review of carpal tunnel surgery, we performed a quality improvement project looking at prescription practices for 4 additional types of hand surgery cases and found the same wide variety of prescription sizes. I sought agreement among my partners that they would attempt to standardize postoperative doses based on the findings of a chart review. I created an educational assist device, which I called the pink card, because it's bright pink and cannot be easily misplaced. This recommended prescription sizes based on the intensity of the surgical procedure, which were in turn based on findings from the chart review. I reviewed our card with the residents, mid-level staff, and nursing staff. In addition to procedure-based prescription sizes, it includes additional pain management strategies. The card, though, is only one of my department's multimodal pain strategy. Preoperatively, we discuss expectations about pain and recovery. We provide patients with a pain contract, which includes probable duration of opioid prescriptions, the risks of opioids, and the caution that we will not provide night or weekend refills. We do not routinely prescribe preoperative opioids. Intraoperatively, it's important to do a local block before you make the incision. Anesthesia research has shown that the brains of patients under general anesthesia can still perceive an incision. You may wish to redose the wound with Marcaine prior to closure if lidocaine only is used pre-incision. You may also wish to consider the concomitant use of an alpha-2 agonist, such as dexmedetomidine intraoperatively or clonidine postoperatively. These are off-label uses per the FDA. Postoperatively, if not contraindicated, we prescribe ibuprofen every 8 hours for 3 days, then as needed. Tylenol can be used if not in a combination medication with an opioid. We prescribe opioids in a consistent fashion. The classic RICE protocol should also be used: ice for 10 minutes, several times an hour, rest the extremity for 3 days, then gradually increase use as permitted depending on the operation, and elevate the extremity above the heart for 3 days, then as needed. Systemically, it's important to educate and get buy-in from nursing staff and mid-level practitioners to allow us to speak as a team with a single voice. Patients do not like mixed messages. It's important to make systemic changes in our electronic health record also to reinforce practice changes. For example, we have no default prescription sizes. We changed the dose instructions from 1 to 2 PO Q4 to 6 hours PRN to 1 PO Q6 hours PRN severe pain. We added ibuprofen and Tylenol to the list of prescribed medications. A checkbox was added that says, quote, "No additional opioids needed postoperatively," end quote, to limit calls from the PACU nurses. And it's important to make a note in the chart when no further opioids are indicated by you, the surgeon. Do not tell the patient to see their primary care physician to get more opioid medications if they were not being treated preoperatively for chronic pain. For patients who are on chronic opioids, it's important to discuss postoperative medication plans with the physician who prescribes their opioids. Do not become the primary provider as the surgeon. It's also important to discuss with the patient their expectations for surgery, the likelihood of pain postoperatively, and the inability to completely block pain. You also wish to stress and to clarify who will be prescribing medication for them and for how long. So what happened after we instituted the changes? We did chart reviews 4 months and 1 year after starting the pink card. For all case types, at 4 months, we saw a drop in prescription sizes. These changes were maintained at the 1-year mark, and more interestingly, we saw a progressive decrease in variation, as per the error bars seen in the graph shown. Our refills also showed a drop by 4 months and then plateaued. Our satisfaction scores have not changed. We drew several conclusions from these improvement strategies. Overall, we determined that standardization of postoperative opioids is challenging but possible. This is an ongoing and fluid practice. We continue work on assessing the true use of postoperative opioids and right-sizing our prescriptions. So how can you apply these principles to your departments and to your patient care? Number 1, choose an index procedure or procedures. It or they should be reasonably common and performed by multiple members of your group. It's important or recommended to avoid complex multi-trauma cases or workers' compensation cases, as the added variability may make the process more difficult. It's also important to consider choosing several index cases of varying levels of intensiveness and invasiveness and operative time. Number 2, get a list of patients who had those cases done from your billing and coding staff. Number 3, review the immediate postoperative prescription size for the procedures and size and number of refills over a 3 to 12 month span, or for a set number of cases per surgeon. Number 4, do basic statistics for each provider for each procedure type. You can look at mean, median, or mode in the number of prescriptions that were planned when you start to create your own pink card. Individually disclose the prescription patterns for each practitioner. The group should see de-identified data. Number 5, negotiate with the members of your group to come to consensus about a prescription size for the index procedure. Choose a number on the lower end of the spectrum rather than the upper. Number 6, for procedures similar to the index procedure, use the same prescription size. Number 7, 3 to 6 months later, repeat steps 2 through 4 to look for changes. Have individual discussions as indicated. Let each practitioner know their data and see if refills have changed. Publicize good news to reinforce behaviors. For procedures where the prescription size dropped precipitously and stayed low, consider decreasing the recommended size a bit further. And 1 year later, you can repeat steps 2 through 4. You can choose not to believe that this is a problem or that you have a role to play in it, but I invite you to start having the conversation with patients. Ask people after surgery how many pills they used or how many they have left. You may be surprised on how many extra opioid pills you have personally put out into the community. This also gives you the opportunity to discuss global pain management strategies and to educate patients on how to safely dispose of opioids. If you have any further questions, please feel free to contact me at Loree Kalliainen at HealthPartners.com. Next, we'll have a demonstration of how to handle common questions that arise in clinics when patients want opioids. Thank you for your time.
Hi, Mr. Johnson. How you doing after your surgery?
Well, I'm doing okay. I still seem to have a lot of pain in the hand. Okay. It won't go away. I can't seem to make it feel better.
Okay. And can I see your incision?
Yeah, sure.
Okay.
Sure.
That's healing really nicely.
Yeah, I know it doesn't make any sense. It looks okay, but I have pain all the time.
Are you still using the pain medicines?
Yeah, all the time. I try not to. I try and back off from it, but yeah, it wakes me up at night, and I'm finding I need 1 or 2 every 4 to 6 hours.
1 or 2 every 4 to 6 hours?
Yeah.
Okay.
Yeah.
All right. Well, with this surgery, we wouldn't expect you to be in pain at this point, 6 weeks out from the surgery. It looks like the incision is healed pretty well. There's no redness or anything to indicate that you have any infections or anything. It feels as though your joints are moving okay. You have full range of motion in all of your fingers. Can you squeeze my finger for me?
Sure. Yeah.
Good. Okay. All right.
I hear what you're saying. I can't seem to make it feel better. And
is the pain getting at all better? From like the date of surgery to now, is it at all better?
Well, sure. I mean,
Okay.
that surgical pain, that sharp pain that I had originally, seems to be a little better. But there's this pain in the hand, and
So
I don't know what to say.
that means we're making progress. So if we continue to treat you with opioid pain medication at this point, there's a risk that we could make this pain worse.
What do you mean by that? How's that possible?
Well, at this point, we're moving from acute postoperative pain into, because we're 6 weeks out from the surgery, we're moving into a chronic pain syndrome, where the pain is the pain at this point is not expected after the surgery, and so we're moving into more of a chronic pain realm, and opioid pain medications for chronic pain are not indicated. They can make patients' pain worse, and they carry other risks like overdoses and addiction. So at this point...
Addiction? What do you mean addiction?
So addiction to opioid pain medications means that you've lost control over how much opioid pain medications you take in. I don't think that that's where you are right now.
I don't think I'd become addicted to these. That's not the issue here. I don't have that kind of personality. I've got pain, and
So
I'm having trouble controlling it.
Anybody that takes, and like I said, addiction is just a risk, okay? It's not, I'm not saying that you have it, but anybody that takes pain medicines, like opioid pain medications like you have, over about 4 to 6 weeks or so, if they're taking it around the clock, they will develop what we call dependence. That doesn't mean that you're addicted. What it means is that if you stop taking them, your body will go through a withdrawal period. Lots of medicines.
Yeah, but if I stop, I mean, the pain comes back again. And
Yeah.
I don't feel any better. I don't feel better.
Yeah.
I start feeling worse again.
Yeah. So I guess what I'm trying to say is that everybody that has pain medicines who's on it for a period of time, like you have been, will develop a dependence. But that doesn't necessarily mean that it's addiction. But there are risks besides addiction that we want to stay away from. And one of them is, like I said, making pain worse after that acute postoperative painful period. If we continue to prescribe pain medicines after the acute postoperative painful period, we may worsen the pain over a long period of time.
Really? Mm-hmm. So what do you think we should do then?
Well, I think you should continue doing the things that are making it feel better, including physical therapy and hand therapy. You can use non-opioid pain medication to help you with the pain.
I tried that stuff. It doesn't work. Okay. You know, I tried the ibuprofen. I didn't get anywhere with that. And Tylenol, it has even less of an effect. That
and
stuff.
There are non-drug alternatives to help you treat your pain as well, like mindfulness and meditation, or acupuncture, or like I said, physical therapy and hand therapy can help too.
Well, I've been to the therapist, and they've given me the exercises, and I think I've come along with them, but the range is good. I think even some of the dexterity is good. It's just this discomfort I'm having, and I think
and the
only thing seems to be the prescription I get. It seems to help. But I don't understand why we can't just keep getting that.
The longer you do those kinds of things, the better the pain will get. But at this point, like I said, we're moving from an acute postoperative pain into a chronic pain, and opioid pain medications are not indicated for any kind of chronic pain. And so at this point, we're going to stop giving you those medicines.
But I don't understand. It's the only thing that works. I mean, where are we going to go from here? It doesn't make some sense.
And like I said, it will progressively get better, but at this point, some pain is still expected. But we're moving from an acute pain to a chronic pain, and at this point, those medicines are not indicated.
So you're saying you're not going to give me any more narcotics?
Not at this point, no.
I'm not sure. I think I'm going to have to go seek an opinion from someone else. I really don't think that's the right answer for me. I think I need something better than acupuncture or something like that.
Okay, and you can do that. I can't stop you from doing that, but the risks with those medicines are the same. You still have the risk of addiction. You still have the risk of overdose.
Now you're accusing me of being an addict, and I'm not sure I appreciate that at all.
You still have the risk of being of continuing to worsen your pain based on the chronic opioids.
But
and again, I don't think that you are addicted to the pain medicines right now. I think that they're not indicated at this point.
Well, I think they are.
Okay.
Where do we go from here?
Like I said, you can continue to do the non-medication therapies, the physical therapy or the hand therapy.
We already went down that road.
Okay.
I need something better than that. That's not going to work for me.
Okay. That's what I have to offer at this point.
Well, I'm going to have to find some other place to get my pain medicine then. I've obviously come to the end of the road with this clinic.
Okay.
Thanks.